Welcome back, everybody, for our next program at the NPA September Virtual Conference. We are thrilled to have our partners at the National Psoriasis Foundation with us for our next program. And in just a moment, I will hand it off to Stephanie Corder for introductory remarks. I want to remind the audience to please go ahead and click on that pretest link in the Events app or web platform and go ahead and complete that pretest ASAP for this program. And without further ado, I'll hand it over to Stephanie for opening remarks.
Great. Thank you, Josh. Good afternoon. My name is Stephanie Corder, Director of Medical Affairs for the National Psoriasis Foundation. Thank you for joining us today for the program Advanced Practitioner Psoriasis Recognition Program. As part of our mission at the NPF to cure psoriatic disease and improve the lives of those affected, we are proud to offer tailored education for advanced practice providers. Today's program is provided through the support of independent educational grants from Amgen, Bristol-Myers Squibb, and Johnson & Johnson. Our faculty today, Victoria or Tori Garcia-Albea, is a dermatologic nurse practitioner and recognized expert in psoriatic disease. She currently practices at Leahy Hospital in Burlington, Massachusetts, and serves as the director of the Leahy Clinic Dermatologic Nurse Practitioner Fellowship. Ms. Garcia is a highly sought-after speaker for dermatologic topics, and we are honored to welcome her here this morning. Tori, I'll hand it over to you.
Thank you so much. All right, we have a lot to cover. I'm going to dive right in. These are my disclosures, and this is our accreditation statement, so you can get credit for this hour of educational content. So we have a number of learning objectives today, and hopefully we're going to address each of these. And if you are taking your pre-test, I am going to hit on all of those questions, so your post-test should be perfect. So we're going to be discussing the pathophysiology of psoriasis as it relates to the identification of targets for therapy, so key cytokines. We're going to delve into the science a little bit. We're going to talk about applying guideline-based criteria for assessing and diagnosing psoriasis. So psoriasis is PSO, that's how we abbreviate it. We are going to talk about how to select treatments for psoriasis. We're going to talk about comorbidities with psoriasis, including psoriatic arthritis, that's PSA. You'll see that abbreviation throughout the talk. And we're going to apply the guidelines that we have from the joint group with the American Academy of Dermatology and the National Psoriasis Foundation, and how that can apply to providers who are managing patients with psoriatic disease outside of dermatology or within dermatology. So you might already know this. What is psoriasis? It's not an autoimmune disease. It is an immune-mediated condition. So that means that the immune cells are involved, but it's not the same as an autoimmune condition like lupus or diabetes or vitiligo or something like that. It involves a complex dysregulation of the immune system. There are risk factors that are multifactorial, behavioral, environmental, and genetic, and we'll get into all of that later on. And basically what happens is that there's a pro-inflammatory state that plays a role in developing the comorbidities that we see in this condition. And it really is a model disease for talking about interdisciplinary collaboration, disease prevention, screening for comorbidities, provider, and patient education. So just to give you a sense of how many people it affects and when, about 3% of the population have psoriasis, which equivalates to about over 8 million people. And then if you extrapolate that nationwide, worldwide, it's 125 million people. So it's actually fairly common. It affects males and females about equally. It is more common in adults. Children do get it, but it's not as common as something like eczema. Plaque psoriasis is the most common phenotype. I'm going to go through the different types that you can see, the different types of presentations. It has this thing called a bimodal peak of onset. So there are two blips on the timeline of when people present with psoriasis. So it's 18 to 39 is a common age group, and then 50 to 69. But when I was reviewing this presentation, I'm like, that's about 21 and then 19 years. So it's 40 years of the lifespan when people can get psoriasis. So it's actually like pretty common throughout the lifespan to develop it. So just because somebody is outside those two ranges of ages doesn't mean that it isn't psoriasis when it presents. And approximately 30% of patients with psoriasis can go on to develop psoriatic arthritis. So, as I mentioned, psoriasis really is a combination of the patient and the environment. We know that there are genetic factors at play when people develop psoriasis, but there are also all of these other factors that play a role. So, we know that emotional stress can trigger a flare. Weather, usually dry, colder weather, can trigger psoriasis to flare up. Certain drugs, so we've listed here the most common categories of medications that can trigger psoriasis. So if you have a patient who we know has psoriasis, you might want to avoid those medicines in that patient. Trauma, so there's this phenomenon called the Kebner phenomenon, Kebnerization, which is if you have an injury to the skin, a cut or a burn, even a sunburn, psoriasis can go to that damaged skin. And then infection, specifically strep. We know that strep pharyngitis can trigger the first onset of psoriasis, and it can also make psoriasis worse if it's pre-existing. So this is a busy slide. It is the only basic science slide we have here, but it's just demonstrating how the new therapies for psoriasis have come from the science of understanding why psoriasis happens at all. So on the left of the slide, there's a normal skin cartoon. And what happens when psoriasis is developing is that the keratinocytes, which are the skin cells, they become activated for some reason. We don't know exactly why. And they trigger other cells deeper in the skin to produce inflammatory cytokines, which then act on other cells to produce more inflammatory cytokines, which then go back to the skin and cause what you can see on the right. I think you can see my mouse. Keratinocyte proliferation, the inflammatory cascade, skin thickening and erythema, and vasodilation. So the keratinocyte proliferation is the thickness of the scale that you'll see on the skin. The vasodilation and angiogenesis is the red or violaceous color that you'll see with psoriasis. So it shows what's happening inside, and then you can imagine it in your head of what is happening on the surface of the skin. And then all of these areas where we see inflammatory cytokines being produced, those are target areas for medications. And they're the medications that target each of these different cytokines are listed here. And you don't have to know every single one. We're going to go through them a little bit later as well. But just know that that's where we're getting all these new medicines from, just the evolution of understanding of psoriasis. Okay, so the phenotypes. We're going to go through each of these. So these are pictures of people who have just really classic psoriasis plaques. We call this plaque psoriasis. So this accounts for 80 to 90% of all patients who have psoriasis. This is the most common type of psoriasis. You can see that even within this type, these are all plaque psoriasis, the amount of scale varies. That can depend on the nature of the disease, and also keep in mind that when patients come to see you, they might already be treating it with something, and so sometimes they're partially treating their psoriasis, and so it isn't as scaly. This central bottom picture is very thick scale. It has a special name called ostraceous, which is from the word for oyster. So it supposedly looks like an oyster shell. So that's just like a little anecdote. If you want to sound really fancy, you can put that in your note. These are two patients who both have plaque psoriasis. It's just comparing and contrasting different colored skins. So the one on the left is a person with lighter skin, and you can see the color of the psoriasis plaques is a bright red. And the patient on the right who has darker skin, those lesions are a slightly different color in comparison. So in this patient on the right, they're a little bit more what we call violaceous, which is a purplish color. And then the size is different, but that isn't based on race or ethnicity or anything like that. It's just purely dependent on the person. So people of all different ethnicities and backgrounds can have all of the spectrum of psoriasis. These are more pictures of different types of psoriasis at different stages. So the person on the left is partially treated, and you can see some of the hyperpigmentation in the center of the lesions, and then the pink border around where it's more active. In the middle, you can see, and actually both of these illustrate that it's usually symmetric. So psoriasis tends to be pretty much symmetric. So if you're looking at somebody with a rash and you're not sure, keep that in mind. So these are thinner plaques with diffuse scale, and then the color is a little bit pink, almost even hypopigmented. And then the person on the right has a classic location of the gluteal cleft, top of the gluteal cleft. But you can see that there probably was psoriasis here. This person's probably on a good treatment. and it's left behind post-inflammatory hyperpigmentation. So post-inflammatory hyperpigmentation is very bothersome to patients, and it's best if you explain it up front, and you can anticipate that patients will have it depending on their skin color. So if they're Fitzpatrick 3 or greater, they're more likely to have post-inflammatory hyperpigmentation. And the more severe the psoriasis is and the longer that it's been present, the more likely they are to have the PIH. It will fade with time. So educate your patients. It's not a scar. It's like a stain, or sometimes I call it a footprint. It doesn't mean that the disease is active there. It's not going to respond to topical steroids. So you want to have them discontinue because it can just cause side effects. Bleaching creams don't work. And so just preparing the patient for the expectation that the psoriasis will fade first, then the post-inflammatory hyperpigmentation much later, 6 to 12 months later sometimes. So here's a patient with active psoriasis on the left, and this is the same patient after their psoriasis was under control, but with the post-inflammatory hyperpigmentation. And even though we don't have a lot of good treatments to make this PIH go away faster, it is important to validate that it could still be bothersome to the patient. So I always ask, if it bothers patients, and just try to reassure them it is going to go away. One thing that you can do is make sure they're protecting from sun, because sun exposure is going to make it darker and take longer to go away. Moving on to scalp psoriasis. So about 45 to 56% of patients with psoriasis will have scalp involvement. So they can have plaque psoriasis and scalp psoriasis. It is commonly the first site that is affected. And because of the location and the fact that it can go undiagnosed, it can be a delay in diagnosis. Sometimes people think it's just dandruff. Sometimes they think they're allergic to their shampoo. And it can be the only area that's affected. So sometimes people will only have scalp psoriasis without any other parts involved. There's an increased association with psoriatic arthritis. It causes significant impairment of quality of life, and it can be difficult to treat. And we are really focusing a lot lately on the alopecia that can come with scalp psoriasis. So the patient on the far right has very active, severe scalp psoriasis. Over time, if that goes untreated, it can cause scarring of the hair follicles, which means the hair cannot grow back. So it is important to assess your patients for scalp psoriasis and intervene early to prevent scarring. Inverse psoriasis so normally psoriasis is in the dry points like the elbows, the knees. This is when it's the opposite. So it's in the folds. So it can be the lower abdomen, under the breasts, in the armpits, and in the groin. It's about a 20 to 30% prevalence, maybe even more, because again, it goes undiagnosed or goes misdiagnosed as yeast infection or intertrigo. It has a significant impact on quality of life. It can actually be quite painful. And sometimes people will have very limited surface involvement, but they will have inverse psoriasis, which we consider more severe because it can interfere with intimate relationships, and it can be so painful. There's also a greater association with psoriatic arthritis with this variant of psoriasis. Here's another picture of a patient with inverse psoriasis. Guttate psoriasis. So the word guttate comes from the word for droplet. So this is supposedly like droplets. If you splatter painted somebody, that there's little drops of psoriasis everywhere. Generally, the lesions are 5 to 10 millimeters. This particular type is more associated with strep than the other types. So this is seen a lot in young adults or adolescents who have a strep infection and they break out in a rash. If you treat the strep infection, it sometimes resolves the psoriasis, but sometimes the psoriasis still goes on to become a chronic condition. It's very responsive to phototherapy. We're going to talk about phototherapy a little bit later. There are two other variants that are rare, but we consider them clinical emergencies. So this is the first one, erythrodermic psoriasis. Erythroderma means red skin. It means that whatever inflammatory process the patient has gone all over their body. So it isn't only possible to have this with psoriasis. You can have it in eczema and other conditions. But if it happens in anybody, including if it happens in a patient with psoriasis, it's considered an emergency because these patients are not able to thermoregulate. They're not able to regulate their electrolytes, and they need to be admitted for treatment and for monitoring. So this is a clinical emergency. Patients usually are having symptoms like fever, malaise, fatigue, severe itch. So these patients need to be sent to the hospital. And then pustular psoriasis is typically the hands and feet. It is more challenging to treat, and if it becomes widespread on the entire body, like the person on the right with these large areas covered with pustules, then this is also considered a clinical emergency for the same reasons. Patients can't regulate their temperature, they can't regulate their electrolytes. It's very common to see this when people have been on an oral or an IV steroid for some other condition, and then as they take that steroid away, their psoriasis goes crazy. Psoriasis is really known for rebounding worse than it was before after steroids. So we always try not to do any oral steroids in patients who have psoriasis. It's also been associated with NSAIDs and lithium. So this is just a little bit more about pustular psoriasis. Again, it's a clinical emergency. It can be in a person that has psoriasis already, or it can be the first presenting sign of psoriasis. You see these widespread pus lesions that we call lakes of pus because they sometimes coalesce together into bigger areas. We talked about the triggers. There is a genetic tendency, which is listed here. And then there's a new medication for it, which is really great. It targets that interleukin 36, and it's working really well for these patients. It's dosed once, and then again, if it's needed, like 2 days later. So that's brand new. These are pictures of hand and foot psoriasis, which is not that common, but not super uncommon. These pictures are fairly severe, but it can be very, very impactful on patients' lives, obviously, because if they can't walk or they can't use their hands, that impacts their entire life. It can be very painful. So if patients have limited disease just on their hands and feet, we still treat them aggressively because of the impact on their quality of life. And then nail psoriasis. So this is strongly associated with psoriatic arthritis. Up to 80% of patients with psoriatic arthritis will have nail involvement. It's not 100% overlap with regular old plaque psoriasis, but always check the nails because that's going to help you screen for psoriatic arthritis. So pitting is on the top left picture. You see little indents in the nail, and it has to do with halting of the production of the nail plate from the nail matrix. You can get oil spots, which are these on the left bottom picture. And you can have what we call onycholysis, which is lifting of the nail. You can see it in this picture as well. Here's another oil spot on the top right. And then this is just more involvement of the nail, called it tracheonychia. The nails can be misdiagnosed, especially if it's toenails. They can be misdiagnosed for fungus. And so a nail clipping will rule out a fungal or yeast infection of the nail, and it will help you be more confident in your diagnosis of psoriasis. And then genital involvement, it's definitely overlooked. We must ask our patients about it because they don't always tell you. It is actually a pretty common location to get psoriasis. And again, even if it's a smaller area that's involved, we treat it aggressively because it's so impactful for the quality of life. And there's a very good soundbite episode about genital psoriasis. So now we're going to move into comorbidities of psoriatic disease, and then we'll get into treatments. So I'm going to go through all of these in the next few slides. So starting with metabolic syndrome, I'm sure you're all familiar with metabolic syndrome. In our psoriasis patients, there's an increased risk for metabolic syndrome, 20 to 50% prevalence. The psoriasis population is more likely to have metabolic syndrome compared to the non-psoriatic controls. So there are increased rates of dyslipidemia, hypertension, and insulin resistance. And as psoriasis severity increases, so does the likelihood of metabolic syndrome. But there's also a relationship with obesity, and this relationship goes both directions. So patients who have higher BMIs have a higher risk for psoriasis, and patients who have worse psoriasis or more severe psoriasis have a higher odds ratio of being obese. So they're independently risk factors for each other. This is what we think is why. So there's evidence to support that obesity is a pro-inflammatory state. The same cytokines that we see in psoriasis are produced by increased adipose tissue. And so the pro-inflammatory state that we know is present in psoriasis also impacts all of the things that we see in metabolic syndrome. So insulin signaling, lipid metabolism, and adipogenesis. The other thing that is interesting about obesity is that it can negatively impact how patients respond to therapy. So if patients lose weight, their treatment works better. So there's some connection there as well. And then we know that patients who have a central obesity and visceral adiposity have a higher risk for psoriasis. And that also goes the opposite way. Patients who have psoriasis are more likely to carry that weight in the center. All right. And then this is an important slide to me. This is a mortality curve. If you control for the same comorbidities and all you look at is whether or not the patient has psoriasis or not, there is a 5-year shorter life expectancy for our psoriasis patients. And to me, that is crazy. There's an increased risk of heart attack, stroke, cardiovascular death, diabetes, and chronic kidney disease. And there's an increased risk for MACE events above and beyond the risk for melanoma. So this is one of the most important slides for this talk because we're talking about pre-screening our patients appropriately for all of these conditions. And I'm going to get into the recommendations in a second. But patients who are younger with more severe disease are the patients that have the greatest risk for MI. And I think that we can easily forget about that. Even if our patient has psoriasis and they're fairly well managed, we still need to be screening for these conditions. So these are the guidelines that were put out in 2019 from the AAD, American Academy of Dermatology, and the National Psoriasis Foundation. And they graded the evidence. You'll see the score on the right. A is the best, B and C are following. So the first one, there's the most evidence that anybody with psoriasis should be screened for cardiovascular risk. So they should be screened for hypertension, diabetes, and hyperlipidemia. The next line down is that we should consider more frequent screening and earlier screening for cardiovascular risk in patients who have more severe psoriasis. And the way they described it in this line is that they're candidates for systemic therapy or phototherapy, or if they have psoriasis involving over 10% of their body surface area. Over 10% BSA is what we consider severe psoriasis. So even if they wouldn't normally meet the criteria for being screened for cardiovascular risk, we should consider screening them earlier based on how severe their disease is and whether or not we are putting them on or they're candidates for systemic or phototherapy. And then the next two categories, there's less strong evidence. So you can consider using a multiplication factor of 1.5 in patients who have severe psoriasis or are patients who are candidates for systemic therapy or phototherapy. So these guidelines just reiterate the fact that we need to be screening our patients at least regularly and then considering early screening for those certain patients. Depression. So we know that patients who have psoriasis or psoriatic disease have an increased risk for suicidal thoughts, behaviors, and suicidal attempts. We used to always blame it on the skin, and we would say, oh, they must be depressed because of how their skin looks. But now there's evidence that similar to with the obesity and the metabolic syndrome, there are shared inflammatory cytokines between depression and psoriasis. So it may actually be more than just what the skin looks like. It actually is what's going on in the skin. We know also that our patients with psoriasis do suffer from social isolation, stigma, and chronic pain, which can also play a role in development of depression. Okay, we're going to move into psoriatic arthritis. These are pictures of patients with psoriasis and psoriatic arthritis. And I'm going to go through the different presentations, but on the left top picture, you can see the nails are involved. Most of the nails are what we call dystrophic, which means they look funny. And then there's redness and swelling on a lot of these distal interphalangeal joints, the DIPs, and you can see that they also have skin psoriasis. This is showing edema or swelling here at this joint. This is plaque psoriasis showing swelling of the knees. And these are fusiform digits or sausage toes with, again, very significant involvement of the nails and psoriasis on the skin. So let me just tell you a little bit about psoriatic arthritis. Again, about 30% of patients with psoriasis will go on to develop psoriatic arthritis. As I was showing you in the previous slide, there are multiple types of presentations for psoriatic arthritis. Just like with psoriasis, it can look differently in different people, but there are some key similarities between all of those presentations. Generally, the skin presents first, followed by the joints many years later. So in other words, people usually develop psoriasis first, and then later they can get the psoriatic arthritis. I'm going to show you a graph that depicts that in a minute. Psoriatic arthritis is a destructive form of inflammatory arthritis. So when I was preparing for this lecture, I was thinking of how we can think about that in terms of the skin. So psoriasis does not leave a scar, but think of psoriatic arthritis as leaving a scar. It causes permanent, irreversible damage to the joints. So we want to try to diagnose that and treat it as soon as possible. Because if you don't, you'll end up with disability and loss of function that can be significant and is progressive. There's an average delay in diagnosis of about 5 years in these patients. And what's terrible is that we can see joint progression of joint damage within 6 months of diagnosis if patients are untreated. So we really need to work to be asking our patients about the common symptoms of psoriatic arthritis and screening for the common features that we would see on the skin that would lead us to be more suspicious about psoriatic arthritis. And unfortunately, there are no blood tests for psoriatic arthritis. There are blood tests for other types of arthritis, but none for psoriatic arthritis. So here's the graph depicting that about 75% of the time, patients develop psoriasis before they develop psoriatic arthritis. About 10%, it's arthritis first, so it does happen, but it's much less common. And then 15% is when people develop both at the same time. Okay, so again, prompt diagnosis is the imperative here. Undiagnosed psoriatic arthritis is common. 10 to 15% of people who have psoriatic arthritis are undiagnosed. Inflammatory markers, again, are normal in 50% of patients. We usually don't do blood tests on these patients to check for arthritis. Again, the delay of diagnosis just by 6 months can cause significant damage that you can see on X-ray. Enthesitis and dactylitis, which I'm going to get into in a minute, are signs of erosive psoriatic arthritis. 47% will develop erosive disease just within the first 2 years of the disease activity. And early intervention can help prevent those joint changes that we see with radiographs. Okay, so here are the different types in a nice table. So the most common type is what we call the distal predominant. So that's the inflammation of the DIP joints. And that accounts for about 50% of patients with psoriatic arthritis. So that's the most common. So if you're screening for psoriatic arthritis, you can ask, do you ever get redness at the tips of your fingers, any pain there, swelling, and it can be asymmetric, and it can be multiple fingers, okay? The oligoarticular is generally just fewer joints involved, and that's usually asymmetric as well. Polyarticular is when it is symmetric. It doesn't always affect just the fingers. It looks a little bit more like rheumatoid arthritis, and it's more than 5 joints. And then there's the spinal involvement or axial disease. This is difficult to screen for because a lot of patients have arthritis in the spine or back pain. So these are the key things that you want to look for when you're screening for back pain. So it's chronic back pain for longer than 3 months. So that kind of rules out whether it was an injury or musculoskeletal. Early onset, less than 40 years of age. The pain is eased by exercise and worst at rest. So this is similar to other types of psoriatic arthritis, where patients will have heel pain that's worse right when they wake up in the morning because they've been lying down all night, or if they've been sitting for a while and then they stand up, it can hurt. So morning stiffness in any of the joints is a really key feature of psoriatic arthritis. And then for the spinal involvement, waking up in the second half of the night with pain, with back pain, that indicates that same thing where it's like the sedentary being still for a while makes the pain worse. And then arthritis mutilans, hopefully we don't see it that much anymore because we have great treatments for this disease. But this is when there's bone loss and bone resorption, and you get what we call telescoping fingers. So that's a late stage sign of psoriatic arthritis. So just going back to a couple of those terms that I mentioned in the last couple of slides. So dactylitis is the swelling of a digit. So it can be a finger or a toe. It is often asymmetric, and it comes from, like, we call it sausage digit because it looks like a sausage. The fusiform swelling is the more technical term, and that looks like a spindle. And so it's narrowing at the top and the bottom with bulging in the middle. The third and fourth toes happen to be the most common, but it really can be any digits. Sometimes it can look like gout and be misdiagnosed as gout, and it's as common as 40 to 50% in patients with psoriatic arthritis. Enthesitis, the enthesis is where the tendon or ligament inserts into the bone, and in psoriatic arthritis, that area can become inflamed. It's very classic on the heel. As I was mentioning, one of the questions I ask all my patients when I think they have psoriasis, or when we're just doing psoriasis follow-ups, is, are you having any heel pain, especially in the morning? It can look a lot like plantar fasciitis, where when they first step out of bed, it hurts, and then as they get moving, it gets better. I usually ask how long it takes to warm up in the morning. If it's less than an hour, that's okay. If it's more than an hour for that pain to go away, that's a concern. So you can see on this profile picture, this swelling here at the enthesis. So that's classic for psoriatic arthritis. And then axial disease. So patients might have ankylosing spondylitis or sacroiliitis. It can result in permanent fusion and structural changes of the spine, just like I've been talking about. Early diagnosis is better because it can prevent joint damage progression. 40% of patients that have ankylosing spondylitis have symptoms of inflammatory back pain, and they usually say yes to these questions. Insidious onset, again, present for more than 3 months, night pain, morning stiffness, onset less than 40 years old, gets better with activity, which is the opposite of rheumatoid arthritis. Rheumatoid arthritis generally is worse throughout the day, like it gets worse as the patient is more tired throughout the day. Not relieved by rest if it's the psoriatic type, but NSAIDs can be helpful. There is a handy tool called the PEST, the Psoriasis Epidemiology Screening Tool, and it is very reliable for screening for psoriatic arthritis. And it's just these 5 questions. Have you ever had a swollen joint or joints? Has a doctor or nurse practitioner ever told you that you have arthritis? Do your fingernails or toenails have holes or pits in them? Do you have heel pain? And have you ever had a finger or toe that was completely swollen or painful for no apparent reason? And if they have 3 or more, you should refer them to rheumatology. And you can just screen at every visit. Okay, so there are other comorbidities we're not going to go into too much, but all of these conditions that are inflammatory have been associated with psoriasis. And so these are sort of more of the up and coming comorbidities that we're looking into. So, all of these should be on our minds when we're looking at patients with psoriatic disease. So we're going to transition into treatment. So there are many treatments for psoriasis. We can start with the topicals. When you're looking at a patient with psoriasis, you should think whether they have mild disease, moderate, and severe. Mild is, we usually define it by body surface area. 1 palm, including the fingers as depicted here, is 1%. Less than 3%, so less than 3 palms on their entire body, if you imagined all their psoriasis squished into into like one area, how many palms would it cover? Less than 3% is mild, 3 to 10 is moderate, more than 10 is severe. Now, there are some exceptions. Like I mentioned, if they have scalp involvement, groin involvement, palms and soles, face, you don't have to have the high number of body surface area to consider them to be severe. So also take into consideration those special sites, the impact on their quality of life, and comorbidities. So we do have a treat to target goal where they did a Delphi process, and they came up with the goal that patients should be having less than 1% body surface area 3 months after treatment initiation, and they should maintain it every time you check them, which is usually about every 6 months. And then an acceptable target goal after 3 months of initiation. So it takes a little bit of time to get to the main goal, which is less than 1%. So within 3 months of treatment initiation, it should be less than 3% body surface area, or at least an improvement of 75%. But this should not be used by insurances to reject or not cover any medications, but this is just an idea for how quickly patients should be improving and how much psoriasis we should see improving in what time frame. Okay, so we're going to start with topicals. We're going to go through phototherapy, oral medicines, and the biologics. So corticosteroids are basically the gold standard. They used to be all we had for psoriasis. There are many, many topical steroids, which I'm sure you're familiar with. We do want to consider where you're putting it and how long you're going to need to use it. So generally, on the face and the groin, we use milder medications, and then we use stronger ones for like the hands and feet where the skin is thicker. Keep in mind the vehicle. So the topical steroids come in many formulations: gel, cream, lotion, ointment, foam, so just consider where you're going to have the patient put it, because if you're having them put it on their scalp, but you're giving them an ointment, it's not really going to work. So keep that in mind. And then the quantity. So if a patient has 10% BSA, first of all, you're not going to only be putting them on a topical steroid, but you need to give them enough medicine to cover that area. So you're not going to just give them a 15-gram tube. We use a lot of times a big jar of triamcinolone when patients have larger areas involved. There are a few nonsteroidal topical agents that we use off-label for psoriasis. So we have calcineurin inhibitors, tacrolimus and pimecrolimus. They've been around for a long time. They work reasonably well. They can sting and burn when you put them on. The nice thing is that they're not topical steroids, so we don't have to worry about long-term risks of use. Vitamin D analogs, they don't work as great as other topical options, but they are completely safe. So if patients are risk averse, calcipotriene is a good option. Keratolytics, their role is to break down the scale. So if you have somebody who has that ostraceous type of psoriasis where it's very thick, no matter what you put on there, it's going to get stuck in the scale. So you need to pair whatever your treatment is with a keratolytic, like the ones listed here, so that that scale is thinned out, so the medicine actually can get deeper into the skin to where the problem is. There are 2 new medications that are topicals that are very exciting. So I'm going to go through both of those. Tapinarof or Vitama, it's a really new mechanism of action. So it's an aryl hydrocarbon receptor agonist. So this is different from most of the other products that we have, which we're always trying to reduce, decrease, fight the immune system. We're always talking about like suppressing the immune system. This is a medication that actually boosts the good stuff in the skin. So it promotes skin barrier normalization and it reduces the oxidative stress. So it is something that I think a lot of patients like hearing about because it is not fighting the immune system, it's enhancing it. So it's a 1% cream that they put on daily. It's only FDA approved for adults right now and only for up to 20% BSA, body surface area. It generally works pretty well. There are some side effects that were reported in the trials. I haven't seen anybody have these problems in real life, but there were reports of folliculitis, contact dermatitis, and headache. The other new medication, roflumilast or Zoryve, is a topical PDE4 inhibitor. We had a topical PDE4 inhibitor already for eczema, and so this is a new one that's available for psoriasis. So it's a 0.3% cream that's applied once daily. This does have the adolescent indication, so it's ages 12 and up. And it works very well for the more sensitive areas like the intertriginous areas. Again, minor risk for side effects, headache, diarrhea, and nausea were reported in the trials, not something that I generally warn my patients about when I'm prescribing it. Phototherapy has been around a long time. We use narrowband UVB phototherapy, so that's the wavelength that targets psoriasis specifically. Patients come into the office 2 to 3 times a week. They stand in this light box. They undress to whatever amount of skin they need to show wherever their psoriasis is. So usually it's down to their underwear. Sometimes they are completely naked. And we have them stand in there for just a few seconds at first, and then we increase the length of time each time they come in. So it usually starts with like 30 seconds, and then we increase it by 10% every time they come in until they're clear. And then we stop them until, their psoriasis flares up again. It's a good option for people who don't have a conflict in getting to the office 3 times a week, so that's a select population. It does take a while, so it usually takes several weeks before they see clearance, but they do generally get pretty clear. And it can be combined with other medications. Okay, so we're going to go into the orals. So there are traditional oral immunosuppressants, which I'm going to talk a little bit about: methotrexate, acitretin, and in another slide, cyclosporin. This box highlights apremilast, which is specifically FDA approved for psoriasis. It's been approved for a while now. It's not technically an immunosuppressant, which we really like, so we don't have to do a lot of blood test monitoring. Actually, we don't have to do any blood test monitoring for these patients. It is also approved for psoriatic arthritis. The main issue with apremilast is that it can cause GI upset, specifically diarrhea, and it's a fairly common side effect. I think it's about 17% of patients will complain of diarrhea. There can be some weight loss, there can be depression or mood changes. It's not as effective as the biologics, which I'm going to get into. Most people get about 50% better. So this is a good medicine for people who have a contraindication to other medications. Maybe they can't come in for phototherapy and they don't want to do a biologic. This is a good option to get them better, but probably not 100% clear. With methotrexate and acitretin, we worry about the risk to benefit ratio. Methotrexate is pretty reliably effective for psoriasis, but we do have to do blood test monitoring. We do liver blood tests right when they start, like right after they start, and we monitor it and space the timing of the blood tests out as they have been on it longer. It can cause bone marrow suppression. It's pregnancy category X. Generally, not used as frequently anymore because we have better, safer options. And same thing with acitretin. It's good for thick scale palmar-plantar disease. It's very effective. Category X, it's an oral retinoid, so it's like in the same category as Accutane. Causes dry skin, and can cause high triglycerides. So that's something we have to do lab monitoring on. But some patients, would prefer this because of various factors. So things that we use, but not as commonly anymore. Cyclosporin we do use. Think of this as a rescue medicine. It works quickly, but we don't want you to stay on it long because it can cause nephrotoxicity. So it's something that we generally have patients on if there's like an emergency. We've got to get you cleared up for a wedding or something, but we always have what we call an exit strategy. So we know this is a temporary treatment, and we're already thinking about what is going to be the more long-term medication after we stop the cyclosporin. So TYK2, or deucravacitinib, is the first oral TYK2 inhibitor that is FDA approved for psoriasis. So TYK2 is in the JAK-STAT pathway of the inflammatory cascade. So this is a novel medicine for psoriatic disease. It is highly effective, works quickly and very well, but this class of medication has some concerns. We worry that it could increase the risk of blood clot. It could increase the risk of skin cancer. The studies showed that actually it's pretty well tolerated. Nasopharyngitis, upper respiratory infection were equivalent to placebo. Headache is pretty uncommon. There can be some GI upset at the beginning, but this is something that is a good option for patients who are young, don't have a lot of risk factors, comorbidities, and who don't want to do an injection. Okay, and then we're going to get into the biologics for the last bit. So we have several. I think we have 13 or 14 now. So I'm going to go through them kind of quickly. How do we choose, right? This is a busy slide, but this is a great slide, and I think you guys get the slides afterwards. So this goes through each of the classes of biologics with whether it's FDA approved for psoriatic arthritis, whether there's a risk for each of these conditions. So the initial biologics that were approved for psoriasis were the TNFs. They're excellent at controlling psoriasis. They do have contraindications, so we don't want anybody who has congestive heart failure or a history or a family history of muscular sclerosis to take those. They are FDA approved for pediatric psoriasis. Then came the IL-12/23s. They're approved for psoriatic arthritis. They're also approved for Crohn's disease. Not as many black box warnings. These are dose dependent. Some of them are weight-based dosing, so that's nice if you have a patient who's heavier. They have an FDA approval for 12 and up. Then there were the IL-23, just 23, which work very quickly, very effective for skin and joints. Their dosing is every 12 weeks, which is nice. The other ones are a little more, well, the TNFs are more frequent. And then the IL-17s, which are FDA approved for psoriatic arthritis and psoriasis. There was a few patients in the study who developed or had worsening onset of Crohn's disease. So there is a question of whether there's actually a link between the two, but generally we stay away from the IL-17s if patients have a history of inflammatory bowel disease. There are 2 that are FDA approved for children 6 and up. And flexible dosing in this category, we can do more frequent dosing. The maintenance is every 4 weeks, but sometimes we can do every 2 weeks if patients need a higher dose. This is a schematic of the potential risks, similar to what I went over on the last slide. But for most of these medications, you're going to screen for history of malignancy. We don't want to put patients on these if they have a history of solid tumor malignancy. And then we always screen for tuberculosis with all of these. So patients will get a tuberculosis screening before they start. So we usually do a quantiferon gold, and then we do it once a year after that. All of them have a lot of side effects that are listed. Adalimumab and etanercept, they came out first, and they have more concerns listed on their label. As we developed more of these medications, we got more careful with how we selected our patients in the studies, so the labels aren't as messy. Sertolizumab or Cimzia is one of the medications that is a little different because it actually doesn't cross the placenta. So this is the medicine that we usually favor if patients are considering pregnancy or are pregnant. So continuing with the biologics, it's just the different classes and different colors, and then which risks they have associated with them. Again, most of them are going to list upper respiratory infection, nasopharyngitis. Some of these studies were done during COVID, so sometimes they'll have COVID, as a risk factor or like as a complication, depending on when they were in studies. Most of them are extremely well tolerated when we screen our patients appropriately. So we always ask if they, again, have malignancy. We ask if they have recurrent infections because these are considered immunosuppressants. So if patients have chronic recurrent cellulitis, or if they've had any issues with chronic mucositis or anything like that, then we might stay away from certain categories. And then just to wrap up, special circumstances. So these always come up when we're talking to patients and families. So vaccinations are recommended while patients are on biologics, but we want to avoid live vaccines. If we think there is going to be a live vaccine needed, it's best to do it before they start their biologic, or if you're not sure, you should just reach out to whoever their prescriber is. Unfortunately, a lot of times we have to have patients off of these medications for a long time for it to clear their system. Like I just looked up risankizumab today because I had a patient on it and we were talking about the shingles vaccine. That half-life is 28 days. So if we were going to wait 2 to 3 half-lives, they're going to have to be off of it for 2 to 3 months and then get their vaccine and then wait for the seroconversion, usually 2 weeks. So it's obviously sometimes necessary, but it's always best if we can do the vaccines before they go on these medications. Pregnancy, so there aren't any large-scale trials on this population. We can extrapolate from other research literature whether these are safe during pregnancy. There aren't any that are done specifically on patients with psoriasis. We're working on recommendations. There's some pros and cons. In an inflammatory state with psoriasis and psoriatic arthritis is not healthy for a baby, to be pregnant with all that inflammation. So there's some support of continuing the medication, but then there's the unknown risk of what could potentially happen. So as I mentioned a couple of slides ago, certolizumab, which is a TNF blocker, that is our preferred one because it doesn't cross the placenta. So if you have an option, if you know the patient is going to be trying to get pregnant or again is pregnant, then that's your pick. And generally, these are deemed safe in general, most biologics are deemed safe for the first half of pregnancy. And then if the mother does continue the treatment during the entire pregnancy, you would want to delay live vaccines for the infant until the maternal antibodies are out of the system, generally 6 months. And then pediatric psoriasis. So again, not as common as it is in adults. About 4% of all dermatoses that we see in kids are psoriasis. Generally, the onset is between 7 to 10 years of age. The majority of cases are mild, and we treat with topical steroids. Again, if you see a kid with psoriasis, especially guttate psoriasis, think of strep. The occurrence of comorbidities are also there in our pediatric patients with psoriasis. And just keep in mind the psychosocial components of psoriasis. And again, there are biologics that are FDA approved for our younger psoriasis patients. So if the disease is severe, we do have treatment options for them. And then surgery. This is sometimes a question, I'm going to have a knee replaced. Do I need to stop my psoriasis medication? Generally, no. Most biologics can be continued through low-risk surgery. If there's a moderate to high-risk surgery, it's a case-by-case basis. Again, we don't want to have that super inflamed skin while we're going under the knife, but it's a decision between the provider and the patient and the surgeon. And then here are some patient resources. Soundbites is an excellent resource. It's presented by the National Psoriasis Foundation. It's little audio clips of people being asked about certain conditions. Psoriasis.org is the National Psoriasis Foundation's website. You can scan this QR code. And with that, I just wanted to thank our sponsors again, Amgen, BMS, and Johnson & Johnson. And just to summarize, psoriatic disease is a complex immune-mediated process, not just flaky skin and creaky joints. Psoriasis is associated with a number of comorbidities, which we went through, that impact not only the quality of life, but the physical function, morbidity, and mortality of our patients. We want to identify and screen for comorbidities. It is our responsibility in dermatology and other specialties, and we really want to collaborate with all the people who are involved in our patients' care to optimize their care. And an educated patient is an empowered patient. Thank you very much.
Excellent. Thank you, Tori. We have some great questions from the audience that we'll get to. And I also want to point out for folks to please complete the post-test and evaluation link that is in the description section of this program. The certificate for this program will be sent directly from the National Psoriasis Foundation. So once again, that post-test evaluation link is in the session description, and your CE certificate for the program will come directly from the Psoriasis Foundation. And Tori, let's get right to it with the questions. The first one is, what is your recommendation of what we can do in primary care before we refer to dermatology?
So I would say diagnosing. So if you feel comfortable diagnosing psoriasis, that's your first step. And then think about whether it's mild, moderate, or severe disease. I think mild to moderate, you can definitely manage in primary care, especially if it's mostly going to be treated with topicals. If you're getting into the more moderate to severe psoriasis and you're thinking they're going to need a systemic agent, that may be when you should refer. But it's totally reasonable to start with topical steroids or one of the topicals that I discussed. If you think they need phototherapy, then they're going to need specialty care. But it's better to at least put them on something. You know how long the wait is to dermatology. So you could have them start their topicals products, whatever you choose, and then also place the referral so that they come in already kind of on their journey. That's totally fine. Pictures are also always good, especially if you are referring, because if you're treating and then it's getting better, it's good to see what it was like before so we can better qualify whether it's like mild, moderate, or severe.
Excellent. You had a 2-for-1 there, because the next question was, what's your recommendation for a primary care provider that can't get a patient into derm for 6 months or so? So
Totally.
that there is exactly what you can do for that patient. Our next question is, other than weight loss, what is the most significant lifestyle modification that somebody can make?
Probably quitting smoking. I know people still smoke, but if they're a smoker and they stop smoking, that actually improves their psoriasis. And obviously it's going to do, other benefits to their general health as well. People always ask, psoriasis patients often ask us, should I change my diet and those kinds of things? And I always say you can change your diet. You can go gluten-free if you want, but there isn't any hard evidence showing that works for everybody. There are certainly people who say I went gluten-free and my psoriasis got better. So I think getting enough sleep and quitting smoking, probably the top two.
Excellent. Thank you. Next question is, do gout and psoriasis sort of go hand in hand?
No, it's just that psoriatic arthritis, those swollen toes, can look like gout. So I'm sorry if I kind of went through that too quickly. Gout is not more common in patients with psoriasis, and the way those toes were looking, it can look like gout, but it isn't gout. So it can be misdiagnosed is what I meant. So it's not, it doesn't overlap. It's a different condition.
Excellent. Thank you. That concludes the questions that we have from the audience today. So, Tori, we can't thank you enough for being with us. And I also want to sincerely thank Stephanie and the National Psoriasis Foundation for helping to support this program today. One final reminder, please go ahead and find that post-test and evaluation link in the session description. Go ahead and complete that. The certificate for this program will come directly from the National Psoriasis Foundation. If you have any issues or any questions surrounding it, you can always send an email to npace@npace.org, and we will help point you in the right direction. We're going to take about a 15-minute break. We will be back at 2:45 p.m. Eastern Time for our next program. Thank you so much, everyone.
Thank you.